obviously there have been multiple clinical trials that have evaluated luspatercept in the management of transfusion-dependent anemia in people who have MDS, and starting with the PACE trial, moving on to the MEDALIST, and more recently the COMMANDS trial, which placed the drug essentially for frontline therapy, comparing the patients who had low to very low, actually low risk and intermediate, in comparisons with ESAs, which have been the cornerstone of therapy of low-risk disease for a very long time. So with that, I'm curious, what is your personal perspective on ESAs versus luspatercept for the management of anemia and low-risk disease?
Well, I think that, with the COMMANDS trial, it's really established luspatercept as really the primary form of treatment, given the significant improvement and hematological levels of erythroid, as well as the reduction in transfusion burden. So really meeting that primary endpoint and also having this improvement of duration of patients being transfusion-free. And really, when you look at the COMMANDS trial and you look at the subset of patients, while the study wasn't powered to show difference in presence or absence of ring sideroblast or SF3B1 mutations, nevertheless you see this improvement for luspatercept in this patient group. So I think certainly for patients that are low-risk disease, who have received transfusion before, this is really the go-to regimen. And it also raises a question of perhaps that this should be the preferred treatment even for patients that are not transfusion dependent. So I personally have really moved forward to using luspatercept in the primary setting for most patients, if not all.
Yeah, and I would agree and definitely echo that. I think some of the interesting things that we sort of found in our clinic is patients can respond really relatively rapidly. So even after a couple injections, sometimes people rapidly respond to luspatercept. Obviously, as was mentioned, the duration of transfusion independence, I think, is the most important thing for our patients. Because obviously quality of life is significantly decreased by transfusions. And if you can not only improve the amount of people that do not need transfusions over a 12-week period of time, but also do that for an additional year compared to what was seen with erythropoiesis-stimulating agents, it's a huge win for our MDS patients. I think interestingly, something that we've also seen is, when you think about patients, this study was looking at primarily IPSS-R as our prognostic scoring system. So it's low risk based on IPSS-R. So we do have the question and challenge that comes up. What about patients that are IPSS-M, higher risk disease, and IPSS-R, lower risk disease? What about patients with TP53 mutations, ASXL1 mutations? And what has been shown, and what we've actually been able to see in our clinic as well, is those higher risk patients can and do respond to luspatercept, and they do respond to luspatercept better than what we see in the ESAs. And really, the only subset of patients that don't seem to respond well to luspatercept are the patients that have more than 5 mutations. And so again, we are using it in a large number of our patients and having a lot of success there.
Yeah, just to add on to that, since luspatercept has been approved for all low-risk MDS, my preference has been to use luspatercept just because of the superiority that was shown in the COMMANDS data. When they did the subgroup analysis, the luspatercept group was, had superior results in everything except for the ring sideroblast negative, where it was equivalent. It was not superior or inferior. And in my experience, I've seen good responses across the board, as was just mentioned, kind of across all molecular subtypes, even in some of those patients that you would expect would have non-responsive disease or a higher risk by IPSS-M. A couple of groups where I still consider EPO patients who have renal dysfunction and maybe significantly low erythropoietin levels, and may also have a contribution of their anemia from their renal dysfunction. And so, my preference, and to the points that have been made, I've seen some very nice responses in patients who are not SF3B1 mutated and have lower ring sideroblasts.
Yeah, I kind of like your perspective on all of that because granted, we want newer therapeutic agents, though sequencing sometimes is not a question that could be addressed in clinical trials like that, which I think some of the abstracts we're going to be talking about a little later on might delve into some of that. I tend to think that it's wonderful to have other options. I do think that, and maybe it wasn't statistically powered to demonstrate the difference between ring sideroblast negative, those who are receiving erythropoietin, and those who may have EPO level below 200. How many of those patients had very high risk mutations or multiple mutations? It's not known. I think it'd be so helpful to know actually, is there a specific patient population that, to Dr. Benton's note, that may have lower EPO level to begin with, maybe a touch of kidney dysfunction or even without it, and perhaps very few or no mutations that may still benefit from erythropoiesis-stimulating agents. And at some point, when they lose that response, you have multiple other options that you could provide. So it's that sequencing that I think is something that we all as practitioners need to think about. But taken all together, and again, granted, in the COMMANDS trial, most of those patients tend to have RS positivity, which, the point of saying RS negative patients do respond better or not, I'm not sure that it was adequately answered in this clinical study. So it's not to say that it's wrong to do luspatercept, because you're still going to be able to derive the same benefit. The response rate is more or less the same. So, but I think it's important to hash out the small little differences that might make a difference to our patients. And then relative to the molecular mutations, I think that that's also very relevant to our patients. If, for example, Dr. Komrokji looked at the COMMANDS trial and he, again, looked at the frequency of mutations and how that might correlate with response. So if the data pan out such that patients will have very, like multiple mutations, over 2, over 3, and they have very low response rate to EPO, I think that could be practice changing and very impactful, right? So we all need to know a little bit more about what happens in someone who may have low EPO level, ring sideroblast negative, and very low mutational burden. How might they fare?